think it depends on what time the occlusion occurred. I have had, unfortunately, friends from Houston, please ignore me. I have had a case which had a occlusion very early after Eluvia stenting, but I think that was because I did not achieve a good enough outflow from pop to the foot. So in that case, I wouldn't think it's the problem with the paclitaxel or the stent. But if this occurs, 我们下午的会议即将开始，请下午第一个 session 的 faculty 到台前准备。谢谢大家。我们请下午 session 的 faculty 到台上就定位，谢谢。
Dear college, welcome again to the afternoon session. It's my great honor to open the afternoon section. My name is Wei Gongzhen from Ida Hospital. I will introduce my co-chair, Dr. Tan from Singapore, and Hong Kong, sorry. And we also have陈永芳医师、朱光华主任，还有蔡伟忠医师、林俊宇医师 ，and also the commentator 谢国良医师、黎明贤医师、黄世涵医师、薛书凯医师 ，and also the 钟清华医师、蔡义佐医师、郑义佐医师，对不起，王维婷医师，还有蔡仲明医师。好，now we should see the result of the morning section with the IDA. Okay, we found the wrong one in the China hospital. IDA sensei, please, you can report your result in the case.
Okay. So, can you hear me?
Yeah, we can hear you. Please
Okay.
Go ahead.
So we have a very complex external iliac artery case. And we established a bidirectional approach from the left common femoral artery with a crossover sheath, and a sixth bench was placed at the right common femoral artery. So I want to try to recolonize antegrade, but unfortunately, vessel was perforated due to the diagnostic catheter. So after that, the wire was successfully crossed the region to external iliac artery. The eventually the wire advances in the hypogastric iliac artery like this. So we check the tip of the catheter just located at the internal external artery. So we did the snare catheter externalization using the snare catheter. And finally, we successfully closed the external iliac artery region. So after that, I implanted the 8mm self-expanding stent here, the Everflex 8x100. And we also implant the 10x40 the self-expanding nitinol stent. After stent implantation, the lesion was dilated with a 7mm balloon catheter like this. So here is the final angio. But unfortunately, we have some leakage coming from the also the external iliac artery as shown here. We took angio again, that another angle. Here. So can you see the vessel perforation? Can you see the vessel perforation? No? Here is angio again.
Yes. It's
Yes.
external iliac.
Yes, external iliac artery perforation. So we decided a self-expanding cover stent for the posterior external iliac artery. So before implantation of Vivan stent graft, we firstly performed the balloon tamponade using the 7mm balloon catheter for the posterior external iliac artery, and we also checked the ACT and use the protamine for reverse the heparin. I exchanged the sheaths from 6 French to 7 Frenches. I checked the posterior the hypogastric artery, and I implanted the Vivan stent graft here, like this. Here's the final angiogram. I think the vessel perforation was managed by the Vivan stent graft. The right common femoral artery, pulsation is very good for right common femoral artery. So we can complete this procedure. Is there any comment or question from the audience?
Yeah, what wire did you use to cross the lesion, Ida-sensei?
Finally, I 035 Telumo wire.
Right. And the cover stent is Vibron.
Yeah, Vivan. We changed the wire from 035 to 018.
Right.
From the lateral grade, from the right common femoral artery.
Okay, Dr. Ida, yeah, very successful case and very successful saved the case. Thank you.
Thank you very much.
我们转到中国第二间 Room 2。Hello, Room 2. Can you hear me?
This is Kevin.
Dr. Xu, can you hear me? Dr. Xu.
这边先上网支援，就按那个 case 顺序这样。我看一下给我 schedule。
Calvin, hi. Have you?
Yeah.
Yeah, hi.
Yeah.
Have you completed your case?
Yeah.
Can you please show us your case result?
Yeah. Can you show it again? Round 5。哎，第5个 round 可以吗？Hello。Okay. See, the occlusion size is about 4 to 5 centimeters. Both sides we can see a little sharp angle, but it's difficult to penetrate. So already 2 experts failed to penetrate the lesion. Next. We use a long shuttle to give better support. From a femoral vein is 65 centimeter destination sheath. From right fistula is 45 centimeter hollow shuttle sheath. And inside 2.6 French CSI with V18 wire. 下一个 round. 再下一个 You can see from hand, the wire can go to a very tiny branch. You can see when CSI pull back, we do the angiography, see the very small vein up to the neck. 下一个 round. 下一个 And then we try to attack from below. 下一个 The resistance SI we use a 2 millimeter balloon to dilate as possible as we can. 下一个 We think maybe we are in the same plane but not. 下一个 We use snake but cannot trap the wire. 下一个再下一个再下一个And we yes, and we try to penetrate the lesion again from above, and finally wire can penetrate through this tiny tract. And what are we doing next is just stare the wire out with externalization. 可以下 table externalization. Then do the balloon dilatation, and we do the IVAS, and she shows the vessel size as around 8 to 10 millimeter. So we put the biobond 11 by 5 centimeter. 最后一个 round 好了。And we use 10 millimeter balloon dilatation. And it's the final angio. And the pressure gradient decrease from 压力多少降到多少？深深下回。31降到多少？40 pressure decrease from 44 systolic to 10 mercuries. Yeah, so pressure gradient also decrease a lot. And this is the case. Any comments from the panel moderator? But so the vessel is not parallel, so we did not show the technique how to perform a feedback re-entry device. But in this area, feedback is also useful. If the final we still fail and there are 2 parallel vessels, then feedback can be used. Yeah.
Kevin, any comments about the choice of the cover stand, Vibron in this case, instead of a bare metal stand?
It is a Viabond, heparin coating Viabond. Yeah.
Yeah. So why the cover stand instead of a usual bare metal stand for this case?
In my life, I never use bare metal stent. And so for me it is always cause a disaster after you use a bare metal stent. And sometimes when the stent occluded, you might have no chance to recanalize the stent ever. So my strategy is always balloon, go home, see you next 3 months, or stent with wire bond. Because once if the wire bond is occluded, and it is more easy to fix. Right. And I'm not sure the result because maybe I should put longer to across the clavicle. But due to a sponsor consideration, and we already full cover the lesion. And for if the left side valve bound for left innominate vein, in our center, the patency rate is 100% in the past 10 to 15 years. But just left innominate vein, we will not let our stent to across the clavicle.
And any concern about, in this case, covering the jugular vein inflow?
No, you can see there is no, already no right jugular drainage. And even if we have a jugular vein, there is all right to cover. It will always go from the other side, so that's okay. Left subclavian vein is well patterned. Oh.
I'm Xie Shukai, and congratulations for a successful case. And I think it's very important for very good catheter, guiding catheter, guiding sheath support in this case with the 45 centimeter guiding sheath, and sometimes we may need additional guiding catheter support if CTO lesion is very long, and additional microcatheter and for probing and sometimes knuckle wiring. And but in the past, I also have experience with Venovo or every stent, bare metal stent in this kind of central vein, and the result is also showed promising. And so, do you will think about this kind of stent in this CTO region?
I can see your result, but I will not deploy. I'm the first one to deploy Venovo stent during live demonstration in Taiwan, and after use IVAS finding, you can see the very long and very big, and the strength is very, very good, and the angio result is very good of Venovo stent. And if you put a wire bond, the angio still looks good, but the IVAS is not as good as a Venovo. The stent will always show an oval shape because the strength is not enough. However, interestingly, for left innominate vein, the wire bond patency is 100%. Yeah, I don't believe a wire bond will occlude in this area. And for bare metal, it always causes in-stent restenosis. So in that case, Venovo stent it is re-occluded in 1 month or 2 months. So we rescue that case by wire bond, and then it never occluded again. Yeah, so you need a graft stent in a central vein. In my opinion, use graft stent or use nothing but balloon. Certainly, everybody has his choice.
Okay. I'm Dr. Zheng from Taichung Tzu. Thanks for the successful wiring and case presentation. And in case of failed wiring, what kind of the re-entry devices would Professor Xu choose, and why? Thank you.
If the final angio, I can make sure the veins are in a parallel situation. At least there will be a 2 centimeters, 3 centimeters area to let me to do the re-entry puncture. Then I will use the re-entry device. Yeah, and it's very easy to use. So, like in my SFA practice, I rarely use retrograde punctures because if antegrade fail, just use re-entry puncture and save a lot of time. And it's more safe, I think.
Oh, Dr. Xu, thank you for your excellent case and congratulations for your successful case. I am afraid we will leave you now and go to another room to see another case. Thank you again. Now we'll go to the Zhang Ji room 2 for another case.
This is not total occlusion, near total occlusion. Okay, okay.
Room 2?
I just want to pass the region with the CXI or Rubicon 150. You have a Rubicon?
Room 1?
Rubicon. Elliot?
Hello? Can you hear me? Zhang Ji room 1, can you introduce your case and your team?
Microcatheter. Rubicon or CXI? CXI, Rubicon. Oh, CXI, okay. 418. A9那条我们漏了。
Room 1, can you hear me?
是龙湾。Yeah, we can hear you.
Yeah. Can you introduce yourself and your team and also your case? Thank you.
Thank you, Chairman. This is Room 1 and Dr. Lai, Zhong Lai from Taichung Veteran General Hospital. We demonstrate balloon pulmonary angioplasty in the CTAP patient. And my first assistant is Dr. Xuelin Li, also from the Taichung Veteran General Hospital. And also our local hospital's assistant, Dr. Shi. And I will introduce our case briefly. They have a slide or your slide?
Can you show me the angel?
Your slide.
Okay.
Okay. So we just introduce this case. This is 40 years male. They have hereditary spherocytosis, and it causes CTAP. It's diffuse pulmonary emboli, chronic thrombotic. He had received 4 times balloon pulmonary angioplasty, includes right lower, right upper lower, and left upper lower. This time he admitted for left lower and left middle lower pulmonary angioplasty. This is the first pulmonary angiography. This is one. Okay, this is the first pulmonary angiography. We use a guiding catheter, is a long sheath guiding catheter into the left pulmonary artery, and use an ALO 1/6 guiding catheter approach into. This is A7 and AA branches of the lower. You could see with the left side on the frontal views, left side. There's a near total occlusion vessel is A7, and the right extension to the extension line long side is A5 branch. Okay. Next, please. And we approach this with shown blue wires with 2 balloon support. This is try to close the A7 near total occlusion. You could see under the support, the wire can cross the total occlusion. Next. And do the 2O balloon dilation. Next.
So what wire did you use?
It's a shown blue wire.
So cool.
It's a regular Woodhouse wire.
Okay.
It's a 2O balloon dilation. Next, please. Next. Just enjoy. You could see that after dilation, the A7 shows a much better support. More branches can be seen. Oh. So you still can see some residual thrombus, coronary thrombus over the ostium over S7, but this is fine. If you open the total occlusion lesions, you don't have to do the perfect. Yeah, in the beginning, you cross the floor vessel will get bigger. You could see the AA is out of proportion larger than A7, so A7 definitely not so small. Then we shift to the AA approach. Next slide, please. Next. Oh, we do the small branch. This we cross the AA, and we use a tool to create a small canal. Next. And next. And we use a 4O balloon to do the much better balloon dilation.
And do you use IVUS? Do you use IVUS to guide your balloon size?
No, we don't use IVUS. We use eyeball.
Angel guide, right?
Yeah, because also we don't use NC balloon. We use a regular balloon, especially in very the C-type lesion. Sometimes, if occlusion too long, the vessel is very fragile. If we use too much aggressive dilation, sometimes can cause a complication. So related, we use if the subsegment, we use 3 or 4. If a segment, we use 4 or 5.
Right.
But most of the time, we use the regular balloon, not NC balloon.
Yes.
But right now, we in local side, the biggest regular balloon is 4 or.
So
we use a 4.
Sorry, so you all use the undersized balloon. And
Actually,
how about the pressure? You will go to high pressure?
Around the A, around 10, depend. Those the maximum are around 10. Regular is 8. You could see when we do the forward balloon dilation, you can see a little creep created when the balloon inflection. Right here, you see that means you just dilation the lesion. Because some lesion we could not see by the angiography very clearly. That's an intravascular web lesion or neck lesion. So sometimes you cannot see it very clear. But it's very apparent when you wiring. We can show another, so we do the A10, you could see the wire advance is very difficult. Even the angiography see not so bad. Okay.
So Dr. Lai, I see you are using the AL guide up front. Any reason why you use such aggressive guide up front, or instead of the JR or the MP guiding?
Oh yeah. If we're dealing with inferior lobe, we use AL or MP guiding, depend on the vessel's condition. But I pick up AL because it's more convenient, because they can approach all the inferior branch most of the time, and even the A4 or A5 branch. So I prefer AL first. But if the vessel is very straight, or sometimes I use MP, I will change it to MP, because MP actually better support than AL in some region. Yeah. But the JR guiding is not very suitable for inferior vessel, because inferior vessel, many branch, very tortuous. So we use JR guiding, the tip is very curved. So you cannot control JR guiding very well in this condition. So AL or MP is a better choice. And this is A10, is right? A10 wiring. A10 beginning initial angiography. A5 final. A8 的最后。A8 的 final. This is the A8 的。对 A8 的对。This is A8 the final angiography. We could see after we do the balloon dilation, it's showing very nice venous return. Go.
Okay, Doctor, you can
right
please keep on your work. Now I'm afraid we should leave you now and go to another room to see another case, and later we'll come back again. Thank you.
Thank you.
So we move the wrong one in Zhangji.
Previous one. Previous one. Okay. Knee joint, knee joint, knee joint. Okay, there.
Hello?
Okay.
Dr. Lee?
Part of the here. So.
Can you hear me?
Yeah, I can hear you.
Okay, can you introduce your case and also your team?
Yes. Good afternoon, everyone. My name is Jaewon Lee from Korea. And
Case number 12. This patient is a 56-year-old man with type 2 diabetes, hypertension, and dyslipidemia. He also had internal fixation surgery for lower lumbar spine. This time he sought medical help for claudication. His right side ABI was not measurable, and his left was 0.3. Lower limb CTA found diffuse stricture or near total occlusion over bilateral superficial femoral arteries and popliteal arteries with small collateral vessels. There was also multifocal stenosis noted over bilateral anterior tibial arteries and tibial peroneal trunk. We will be dealing with the right SFA as well as BTK lesions today.
Previous year.
Okay, Dr. Lee, can you explain what's your strategy today?
Okay, the patient is visited with intermittent claudication, and CT angiogram showed severe calcification at the common femoral artery and distal femoral artery, and then prohibit the interpretation of stenosis. So we actually the recommend to the ipsilateral integrated approach, but there is a huge calcification located in the right common femoral artery, so I choose the contralateral approach from the left femoral artery, and then I perform the coronary angiogram first, and there is a disease of the calcified disease located in the circumflex artery. Then I check the angiogram with the right juncting catheter like this. There's a very hostile aortoiliac angulation with calcification, so that is a problem to use a crossover approach. And this machine is a small head, so I cannot apply a DSA easily. So this is a moving angiogram. You can see there is a tight stenosis located on the proximal SFA ostium with a calcification. So I want to use a atherectomy system for the proximal SFA calcification, as well as maybe there is some disease that the distal SFA can be also treated with atherectomy. So I use this is a 8 French 45 centimeter cyst. So 7 French is okay, but 7 French cyst is not available at this moment, and this kind of high angulated area, 8 French is better for the atherectomy system device. So I chose 8 French telomosis. This is angiogram after engagement of 8 French system. You can see there is a mild to moderate stenosis with a calcification at the common femoral artery and tight stenosis at the proximal SFA. So I am trying to passing the lesion, and now this is a CXI and radius 018 guide wire past the lesion, and I check the distal part angiogram because there is a scanty peeling of contrast because of tight stenosis. So I inject contrast through the microcatheter. There is a diffuse calcified stenosis located at the mid SFA, and this is a distal SFA. Yes, there's a distal stenosis is not so tight, and this is the proximal SFA, and this is current situation. Could you comment on some strategy for this case? Okay, there is some calcific nodule located at the P2 area. This is a angiogram. day. Please give me some comment and some suggestion. NAV6 주세요. NAV6. Emboss shield. Emboss shield. Filter.
Hi, totally. I think the distal SFA definitely looks very calcified. Even on the angio, you can see the circumferential calcium.
Yeah.
And also it's a irregular calcification intraluminally. So definitely I would check the IVUS after crossing my wire, and then probably to consider any sort of atherectomy for this case.
Yeah. Wait. So another comment. Okay. I'll insert the guide wire again, and I'll check the IVUS, and then I'll explain the IVUS finding, and then consider atherectomy or not. Okay? Because the angiogram is not so clear for the luminal narrowing at the distal part P2 area, and proximal CFA also, the contrast filling is very scanty, so I cannot understand the exact anatomy. So I'll check the IVUS first for the P2 area and proximal CFA, then I will consider just DCB angioplasty or atherectomy and DCB angioplasty.
Okay, Dr. Lee, please keep on your work, and we have have the lecture first, and then we'll go back to you. Okay.
Okay.
Now we have the first lecture in this section. The first lecture is will given by Dr. Lin Junyi. Dr. Lin Junyi. Our topic is the PAE in the BPH patient. So, Dr. Lin, please.
Hello, everyone. I'm Luca. I'm TSIR General, Secretary General. Today, I will give a small talk about posterior artery embolization, how IR doctors do. How to do a comprehensive evaluation for PAE procedure. First, you can do ultrasound to assess posterior size and if there are any local lesion. And we know the intravesical posterior protrusion, IPP, it means controversial for the PAE technique. And because we are IR, we also are diagnostic. So we do the MI evaluation for the high PSA level patient. And you can see some occult lesion when they have BPH. So we do the urodynamic study for minimal invasive procedure, but it's very important because you must test the bladder compliance and check the meatus stenosis possibility. And we do the CTA evaluation before the PAE. It's the most important thing we do because they provide a detailed vascular image, 3D reconstruction information. And we do the different puncture. We use the ultrasound real-time puncture to give a precise puncture. And our machine have a combing CT. It's very different from the CB for cardiologists. I will show some 3D imagery about the combing CT. It's an example of the left. The picture on the left is a normal posterior gland. We can see the central gland and the peripheral ring. So a patient maybe have a BPH. I mean, this one is a BPH. It's from the central gland hypertrophy and also have a prostate cancer and the peripheral ring. So MRI for the PSA high-level patient is very important. And how to do your first case of the PAE? I mean, maybe the huge prostate is the most easy case to get one because large size prostate maybe cause a complication or more difficult surgery, okay? And this example for CTA before the PAE. I mean, I can use this color is show the right side and left side prostate artery is origin from the obturator artery. And the obturator artery both origin from the external iliac artery. So if you do not do CTA before procedure, you may waste your time in the internal iliac artery. You may get no answer in your procedure. This is how IR puncture. We puncture by the sonor guide. And I hide my guide wire within the needle. I see some blood in the hub. So I just put the guide wire under the sonor guidance. It's very easy for IR. And there's a different position because we do combing CT in the procedure. So we always put the patient's hand over his left inguinal region. So CTA also can be predicted double PA. I mean, the right side PA is one from the anterior trunk and one from the internal pudendal artery. And left side, we can see that both PA is different orifice from the internal iliac artery. And we can combine the combing CT used to see this is a left central grand artery, this is a left peripheral grand artery, and right peripheral grand artery. So we can do the precise imagery for the embolization. And sometimes CTA also can be misdiagnosis. You can see the 2 and 3 branch is both face anterior. But when we do combing CT, the 3 is the radial artery, not the posterior artery. So it's very important to do combing CT in your procedure. And I usually use the NTG nitroglycerin local injection before the combing CT. You can see there's anastomosis to the bubble artery. After NTG local injection, the blood flow is reversed, so we can keep the drug within the prostate gland. Which one is the prostate artery? This one or this one? Maybe you have some experience, so you can, this one is a radial perfusion, but it's a triangle appearance at the low part. So maybe you can imagine it's a prostate artery, but with the anastomosis to the radial artery. The right side one is a round shape, but the final diagnosis by the combing CT, the left side is only the radial perfusion. And right side one, the round shape one is a prostate artery. So combing CT can make the precise embolization. Thank you.
Thank you, Dr. Lin, for your excellent talk. Okay, now we're back to the wrong one for Dr. Lee.
Need to.
Dr. Lee, you are on air now. Dr. Lee?
Okay.
You have done the
This is the area of calcification, and even there is some calcific nodule, but lumen is maintained here. Here, where is this area? We need treatment. Okay. This area we need treatment. Okay, here also. Save. Here. Save floor, please. Here. Wait. Save floor here. Okay, we need a treatment here. So that we need the definitely atherectomy. Wait, a little bit proximal, please. Proximal. Okay, okay. Okay, we need, okay. Where is it? Where is here? Roro. Okay, here, middle part is also, this is the part. Okay. This is the proximal SFA. Okay? Okay. There is a scattered classification located proximal SFA, mid SFA, and distal SFA. Okay. I need a CXI again and NAV6 filter wire, please. NAV6 filter wire. CXI. And we need jet stream 2.4. 2.4, 3.4. Jet stream 2.4, 3.4. Largest jet stream device. Seven.
So Dr. Lee, after the IVUS, what's your strategy now? Which device will you use?
Did you see the IVUS image?
Yes.
Did you see?
Yes, yes, yes.
Oh, yes. There is a clasping nodule located at the community area is relatively, even though there is classification, but lumen is maintaining. But from the distal SFA near the adductor canal, there is a severe focal classification with a very stricture of the artery. There is classified severe stenosis scattered at the distal part, middle part, and proximal part, and proximal SFA. So that's why I need atherectomy procedure for this today.
And what atherectomy device do you have in mind?
Because this is a very long region and relatively concentric region, so I prefer to use a jet stream device for this kind of case. And I always use a filter device. I favor filter system is NAV6, embossed NAV6.
Okay, thank you, Dr. Lee. Please keep on your work, and we will leave you now, and we go to another room, and later we'll come back. So we go to the Dr. Lie's CTF case. Dr. Lie, you are on air again. Hello, Dr. Lie.
Oh yeah. Nice.
So it seems you have finished your case. Can you explain?
Yeah, we finished lower segment. Okay. After A5. After A8 过后的A10好了，给我们看，这个已经，这是A10啊，在前面 A11开始，在前面诊断的时候，我们有个 A10诊断 ，OK， 在前一张应该就 A10诊断。This is A10. Okay. It's inferior lobe posterior branch. You could see that they have two major branches of A10. One is on the frontal floor left side. They have the Weber region over the ostium. And the right side, you see some stump-like region and a very trivial floor into a very small branch. They're total occlusion of the part of A10. So we do the left side first. Next. We cross in the wire with balloon support. You could see that the web-like regions make our wire very difficult to advance. Next, please. Finally, with the balloon support, we can cross it. And it's a little bit hard to push the balloon across the region. So we use a Leopard technique, sequential dilation. And with just strong push, balloon can get inside. And balloon dilation sequentially. Next. 2-0 balloon first, then 4-0 balloon. Next. To the 4-0. 4. It's a 4-0 balloon. Next. 让我们做头痛。 After balloon dilation, it shows very nice venous return of this branch. Then we shift to a left side total occlusion lesion. You could see a very small stump over there. And we change our aerial guiding caster sheath positions and approach the CTO side. And the wire can cross difficultly, and we use two balloon dual dilation. The ostium side. So you could see the vessel open. It's quite large vessel. It's not a small vessel as the beginning. Next. And we use a 4 balloon to the ostium dilation. Next. Preview. This is a 4 balloon to the dilation. Okay, next. This is the final. You could see both of our branch, they are open. And so, because, yes.
Do you use the same wire, the workhorse wire?
The same wire.
Right.
They're all shown blue wire with a 2 balloon support.
Right.
So if you
Very
can,
simple procedure.
Sorry, Dr. If you cannot cause lesion, we'll shift to more stiff wire.
Lots of time, if you can see the 4, you could do that. But the 4 is not very clear. Sometimes very, very challenging. Yeah. But I always use shown blue first. If balloon support cannot cross, I will try the microcaster. If not, and change it to a field FC wire, something like that. If still not cross, I able try the Gaia or Conquest Pro before, if a lesion very, very hard.
And Dr. what would be your sequence of choosing which branch to intervene? Do you always go for a branch at a time, or you prioritize the lesion based on the lesion's severity, like CTO last, and then probably the grade 1, 2 first?
Yes. Yes. It depends on if the CTO lesion, we will open it first. We don't purse a very perfect balloon dilation. But if a weight by lesion, we were looking for much better balloon dilation. Yeah. But CTO sometimes, or near total lesions, the distal vessel sometimes very injured. So if too more aggressive dilation over the injured side, sometimes cause complication. So if a CTO, we open the CTO side first. We will check the angiography 1 month later. If it get better or residual lesion, we will do the optimal balloon dilation at that time.
So Dr. Lai, how many vessels will you interview in one section?
Usually it's around 3 or 4, depend on how many lesions. But if they are all CTO, we open the lesion first. So even we can do 4 or 5 segments. That's not a big problem.
Besides the angiography, is there any other parameter can you measure your success for your intervention? So I know that the pressure is not down right now, but is there other symptom or other parameter you can measure?
Yes, yes. Angiography is usually we use. If you want to measurement, you can do measurement when you finish your angiography. You push your guiding caster more distal to the lesion, and you can measure pressure. It's one way. It's immediately you can see if the pressure gradient decrease. Okay, another is if a lab biomarker, you can choose the NT-proBNP data, VQ scan, the perfusion condition. There can all be some functional images, so you can have the answer. Yeah.
So is there any comment for the commentator?
And I see you are going after the A6.
Yeah, I check AC because I only have 1 hour, so I want to check out the segment.
Right. Very ambitious.
That's right.
You work fast.
Yeah.
Congratulations.
Just one next time patient can save in the contrast. So now we check in the A5.
Right.
Okay. Yeah, that's all. That's all.
Okay, Doctor, thank you for your excellent case. We have another talk right now. Thank you. And now we have another presentation we give Dr. Huang Yuhan. So Dr. Huang, the topic is time in the patient with chronic pain. Dr. Huang, please.
大家午安哈，我是那个星光医院疼痛科的周边血管科的黄玉涵医师。那我今天要讲的题目呢，主要是针对我们 live demo 为主的哈。我们这次 live demo 是一个knee pain的一个病人哈，所以我要讲的是一个 genicular artery 的 embolization 的一个 case 哈的一个稍微帮大家 introduction 一下。那我们可以先看到什么时候去做这个embolization 会效果好，在 KL grade 1到2哈。那如果是 grade 3以上的话，它的成功率大概就只有到70%，可是 total 来讲都还是有80%。那我们可以看到在右边哦，这些都是从一些 paper 出来的一些 data， 对哪些对于 GAE 的效果比较没那么好。第一个就是 high grade 的一个 OA， 然后它可能合并有 bone edema 的 lesion， 或者是还有 meniscal injury 这样子，还有 cartilage 的那个的 loss 这样，或是有一些 effusion 或 bone marrow lesion， 或是有一些 spur 这些的话呢，我们可能要配合一些其他的一些 Pro 或是 PRP 的治疗，效果才会比较好。所以Grade 1、Grade 2的 osteoarthritis 的话的knee OA， 其实它效果是可以达到80到90% 的。再来的话呢，我们要了解到我们今天的栓塞物，它是一个暂时性的栓塞物。这个栓塞物它是 imipanon， 然后我们是利用它在 contrast 里面可以微溶于水跟这个显影剂的这个功用。然后它的话呢，它的 particle size 的话大概是10到130微米。然后它在人体的体内在肾功能里面呢，在肾脏里面，在动物实验里面，它是可以停留大概2天。然后在身体里面、组织里面可以停留到1个礼拜。所以它在这2天到1个礼拜里面呢，它就可以让这些不正常的新生的血管达到一个阻塞的一个作用。然后这一篇是这个 O'Connell 教授他在他的一个 study 它是一个在用 MRI 然后来看这个 OA 它塞完之后的一个情况如何。它有收95个 case， 然后它的 Grade 1是 Grade 1到 Grade 3都有，它追踪4年。那最主要大家通常对 embolization 的最大的疑问是说，它会不会有 major complication 就是因为毕竟我们在周边血管学会，我们对于 PAOD 啊或是一些 ischemia limb 都非常的敏感，所以就觉得我们都平常打通了，那这时候我们塞这样可以吗？其实不用担心，因为它不只有临床上没有看到 osteonecrosis 说 ischemia change， 它还用 MRI 去 follow， 确实都没有这些症状它只有一些可能，比如就稍微轻微的 subcutaneous hemorrhage 或是一些暂时性的皮肤颜色变化。那这里的话呢，是最主要我们今天我们勾了这边的血管的一些anatomy 的部分。我们可以看到这个血管的部分呢，如果是在内侧的部分的话呢，最主要是1、2、4这3条要勾到，就是 superior patellar artery descending genicular artery， 还有 medial superior genicular artery 这样。然后针对的位置会有不同的栓塞的血管。那其实呢，这个血管它其实虽然是蛮细的，可是它的其实我们一般用 micro catheter 或是 1.6 的的外耳，其实那些都是可以进去，都可以还蛮顺利的这样。那这里的话，我们可以看到它的 outcome 的部分呢 ，outcome 的部分在 Grade 1、2的话，它有到90%，到6个月的话还有90%，然后到3年还有80%，可是到 Grade 3的话就明显的下降到大概7%多，快80%。这里就是大家很在乎的，有没有一些 osteonecrosis， 或是有没有一些 ischemia change。可以看到，它追踪完4年后呢，其实它的 synovitis 有改善，而且它并没有一些 cartilage loss 或是一些 osteonecrosis。所以相对来说，这个 GA1 它其实在欧美，跟在日本其实都已经有很多人去从事这个治疗哈。它对于 Grade 1、Grade 2轻中度的 OA 其实效果其实是好的，而且是相对来说是安全的。那整个治疗过程，等一下梁医师会示范，大概也蛮快，大概1个小时左右，8条血管勾完也都是很快就可以完成了。好，我的介绍到此结束，谢谢大家。
谢谢黄医师你进来演讲。Thank you for your excellent talk, Dr. Huang. Now we go back to the Zhangji Room 2. Hello, Room 2.
Start. Okay. This is okay.
Hello,
Start from now. Start. Yeah. Start. Yeah.
Hello.
Yeah.
I just begun. Dr. Lee.
I just begun my
you
procedure.
Are on air again, yeah.
Yeah.
So what are you doing now?
This device is JetStream 2.4 and 3.4 device. This is the maximum size of JetStream device because the artery is big enough and calcification is very huge and the artery is very straight, so I choose larger one. Anyway, I'll do a JetStream device from the proximal septate to the pulmonary artery all the way down twice or 3 times. Then I'll do a maximum tip twice or 3 times. If there is some resistance, I'll do a to-and fro motion at that point. Okay?
Dr. Lee, have you also evaluated the common femoral artery calcified lesion by IVUS or pressure gradient? And
pressure gradient was not applied, but common femoral artery calcification is very huge. But lumen is a little bit maintained. But I'll do a atherectomy from the common femoral artery to the all the way down, and I'll apply DCB from the upper part of a femur head. That means the common femoral artery also treated by DCB angioplasty. So as you can see, I located the NAV6 filter device here, P3 area, and guide wire is located the end of the pedal artery. That means this is almost 40 centimeter safety zone of the guide wire and filter system. Okay, start.
Okay, Dr. Lee, please go your work, and we will leave you temporarily, and we'll come back later. Thank you.
Thank you.
So we shift to the Zhongguo Room 2. Dr. Chen Junji. Hello, Dr. Chen.
Hello. Yes. I'm Dr. Chen. Yes.
Can you introduce your case and also your team?
可以请大会帮我们播一下病例影片吗？
Next case, PAOD with the Rutherford classification 5 with the calcified right popliteal artery. The operator will be the Chen Junji, Dr. Chen, and Dr. Wang Junchen. This is a case of 55 years old lady with underlying dyslipidemia, paroxysmal AFib, and ESRD, for which he had kidney transplantation, and currently kidney status was CKD3 with a 3-vessel CAD, and never had a CABG and PCI with DS. Her ABI is obviously indicating PAOD, and symptom was a poor healing of the right foot wound and Rutherford classification 5. Here is her previous angiography image. Our strategy might be the CO2 injection for CKD patient, and we'll proceed with the popliteal artery PTA. Let's see how the operator will proceed.
那就进来跟他说一下。
Okay, Dr. Chen, what's your strategy for today? Will you use anti-grade puncture or retrograde puncture? Or what's the device will you choose?
That's a very good question. So actually, we just do the access and pull-out sheaths. So let me show our first angiogram. We choose from contralateral side puncture, use the 7 French sheaths. Because the autoiliac artery looks like no significant lesion, so we choose crossover, maybe more easier to control. After the first angio, so we check our next run. Wait a moment. Okay, so this is our second run. We put 7 French cook sheets and do the fan part to BTK. So as you see in the casebook, I think the target lesion only in the popliteal artery may be down to the P3. ATA is totally occluded, but I think the PTA and peroneal is patent. TB trunk, I think, have some mild disease, maybe some eccentric plaque. Because this patient only have the symptom with claudication, so maybe today my target will be the popliteal artery heavy calcification lesion. Maybe today I will use the arteriotomy device to treat this lesion. So any comment from our panel or our audience?
So Dr. Chan, this patient presented with critical limb ischemia with non-healing wound. Is that so?
Yeah. Actually, I think it's claudication. The wound, I think, is only minor wound, not so severe.
Okay.
So,
right.
Yes.
So because if it's a critical limb, then probably we need to treat the posterior tibial and the anterior tibial
Yes.
as well. Yeah, but if it's just claudication, then probably just dealing with the popliteal this time is fair.
Yes. So because I will use the arteriotomy devices, so first I will put the filter. Because we know whether you use the rotational or directional arteriotomy, this toe protection is mandatory. So I just pass my V18 wire, and I will use the spider filter. I think my deploy location I will put in the TB trunk. Okay. Because today I will use the Hawk 1 to treat the popliteal artery.
So, Dr. Chen, before that, will you perform the IVS first or just go
today, today Dr. Xu Zhong also prepared the intravascular image for us. Luckily, we have maybe we can use the OCT today.
So is there any comment or question from the commentator?
Dr. Chen, I'm Xu Shukai.
Yes.
Will you use Hawk for popliteal artery, and how about lesion at the P3 and tibial peroneal trunk? Will consider like just a balloon or cutting balloon or others?
Yeah, I think for this image, I think maybe every operator have different kind of choice. Simply, you can, of course, you can use a plain balloon or some special balloon, like you can use the cutting balloon or the scoring. Try to do a better vessel prepare. But because I think the final device, I think we will use the drug device. In the drug device, I think if we want to do a better vessel prepare, usually just like the core intervention, if we had the intravascular image, I think there will be a better result. And also because this is a heavy calcified lesion, so I think arthrotomy device would be more suitable before the drug device use.
Okay, Dr. Chen, please keep on your work. We'll leave now temporarily, and then we'll back again for
Okay.
you. Okay, thank you.
Okay, thank you.
Now we shift to another room, 中国 room 2. Oh, sorry, 张基 room 2.
Okay.
Hello, Dr. Lee.
Yeah.
Yeah, you are back. We are back again. So we'll see how you're doing.
Dr. Huang is doing his first atherectomy procedure in his life. This is a blade up mode maximum. Tip, okay, slowly. So we need maybe 3 or 4 minutes more for the atherectomy procedure. So, can you hear?
Yes.
Yes. There is some resistance at the proximal CFA ostium. So at the moment, like a rotablation, the small packing motion is very important. Just the dithering is not good, but small packing motion and slow to and fro motion and past the region, so it's important. So I think auditory, tactile, and visual combination is needed for the rotablation procedure. Let's go. Let's go.
So totally, you have already performed the first run for the entire SFA, right?
No, I divide the rotablation procedure into 2. I do a proximal to middle part first.
Okay.
Then I'll do a distal and tamnital part the second.
Right. So you are doing the blade up run. On
Yeah,
the
this is the blade up run. Yeah. There is some sound resistance. That means there is a tight stenosis there. So at the moment, slowly to and fro. Then that area we need a to and fro motion needed. There is some resistance there. Okay. Repeatedly done, you can pass the region. Give some patience. Give some patience. Okay.
So totally, any tips when you're facing resistance, like in this case now?
The patient?
Any tips about what to do when you're facing a resistance, like what you're facing now, when you're advancing the oophorectomy?
If there is some tight portion, very calcified, heavy calcified, tight region, there is some resistance. Thus you can do a more frequent to and fro motion to remove the resistance first. Then you can do a blade up, and then do a same manner with anyway we need some packing motion is needed, some kind of tight region. Okay, there is some resistance here. Okay, I'll do it. Okay.
All right, the master.
Blade up.
Master is going to show us how to do.
Blade up. Go. Okay, this portion we need some tight stance here, so we need this kind of packing motion is needed to. So. Blade down. Okay, go. I'll do a blade down first here. So this area there is a severe resistance here. So I'll do a blade down a little bit more, then I'll do a blade up. I heard that there is a speed drop sound. Okay, like a rotablation, coronary rotablation. Okay, here you can see.
Yeah, I think
There's a
yeah.
free, already crossed. So from here, I'll do a blade up, and but here. Okay, so there is a free of resistance here. Okay. Oh, and another resistance is felt here at this moment. Okay, place down. Okay, go. Okay, let's go. So there is a very heavy calcification scattered all the SFA, so this area is also very tight.
Right, so totally, when it's similar for the rotational atherectomy for rotablation. We look at the burr, the rotational speed on the burr.
Yeah.
For this, I mean, for this jet stream, is there any clue about the deceleration of the atherectomy when it's like going to be stuck on the lesion?
That is felt from the visual and tactile and sense and sound as a mixture of them. So we cannot see the rotablation speed like coronary rotablation. So, but you have to concentrate on your eye, ear, and feeling, hand. Okay. Let's go once more. Okay, I'll change my position to reduce radiation. Okay. Put it down. Okay.
Okay, Dr. Yi, please keep on your work, and we'll leave you temporary and back again.
Okay.
Now we shift to 中国 round 2。
但因为它摆的不是同一个平面了，所以有时候你还是得进去，就像你说，就是看image你有没有 touch 到。
Hello， 阿基。
filter。
You are on air again.
Oh.
So.
We just put our filter, and we try to do the OCT image now. For maybe panel have some discussion about if you will treat this kind of lesion, which device will you use? Because just like I said, maybe someone will use the cutting, or maybe someone will use the rotation atherectomy. I think it's another choice.
Okay. So, anyone give some comment for this heavy cancellation? Which device will you use now? So, how about you, Dr. Tan? Which device will you choose for this issue?
Well, ideally, I would do intravascular imaging first, just to see about whether it's a circumferential, whether my wire is biased to one side, or whether it's right the center, meaning that it's dealing with a circumferential calcium. So for circumferential calcium, probably rotational atherectomy, it's you can get you a bigger and more roundish kind of luminal gain. Whereas if the wire is biased to one side, then probably directional atherectomy can help you debug that heavy calcified side and allow a better balloon expansion. So I think it's probably even more important, as in the popliteal you want to avoid stenting as much as possible. So vessel preparation and then balloon and DCB is preferable probably in the popliteal artery lesion.
Dr. Chen.
Yes.
So what's your choice for this lesion?
Just I mentioned before, I will do the image first, try to identify maybe the most severe calcification part, and I will try to pass the atherectomy device first, because maybe the lesion will be very tight. So the device, if not close, maybe I will use a small balloon to do a dilatation and try to pass the Hawk 1 device, because today I choose the 7 French Hawk 1 I'm not sure if the Hawk device will pass smoothly, so I try to do the image first. Because I use 7 French short sheets, so for the OCT, I will insert a 5 French long sheets. Try to reach the target site as near as possible, so the OCT image will be more clear.
So you plan to use OCT for this case?
Yes.
Okay.
Yes. The patient, although she is a CKD patient, but she already received a renal transplantation procedure 5 years ago, and now the renal function I think is normal, so we can do the OCT without hesitation. So the OCT setting, contrast setting, according to the recommendation of Abbott, I think I will use total contrast amount 20 and the speed is 6. Because this is an auto pullback, so maybe we can see the most suitable length, maybe around 6 to 7 centimeters. Okay, OCT.
So you perform OCT now, right now?
Yes, yes.
Okay, so we'll wait.
So the OCT pullback length, I think, is 40 something or even shorter?
Because you can choose a longer length, so longer length will be maybe around 75 millimeter.
Okay. But you're using the coronary OCT system, the Otis?
Yes, because now currently no peripheral OCT system, so we just
Any
use
tips and tricks about doing OCT in the peripheral system, or rather than coronary?
I think it's more easier to do the OCT than the coronary, except the lens, because we know most of the peripheral lesion is maybe longer lesion with diffuse lesion, so maybe sometimes you need to pull back maybe more than 1 or 2 times. So that's one of the limitations. And other limitation is the contrast usage, because you need to consider about the contrast use. Okay, maybe this is the most part I can reach. Just wait a moment, we connect the OCT machine.
And do you use half contrast or full contrast for this case?
Because the machine setting only can use the full contrast. I know some OCT machine you can choose maybe the half contrast setting, but if you want to use the measurement by the OCT machine, I think currently now we can only use the full contrast. Maybe another choice, maybe for the core intervention in our hospital, we try to use the HAZE solution. It's another option if the patient has chronic kidney disease.
So, Dr. Chen, you can do you can do your OCT, and we go to another room to see another case, and then come back to see the result of the OCT.
Okay.
好，we shift to room 1 for another case. Hello, Dr. Chen.
Hi.
Yeah, welcome. You are on air.
Okay. Good afternoon, ladies and gentlemen. I'm Dr. Zheng Sichong from Everon Hospital. Today, Dr. Lu is with me in this lab. We will do a case of prostate embolization. This case is 先请放那个病人的病历的影片。This is a 72 years old male.
Maybe using Indigo for the our approach. Maybe using Indigo for the
There's some mistake for the presentation.
Okay, I present the case myself.
Okay. Thank you.
This is a 72 years old male. He has underlying paroxysmal atrial fibrillation and received ablation before. And he received coronary stenting with DES in this August because of the dual antiplatelet therapy. So he want to receive PAE. We can keep the dual anti-therapy during the procedure and post the procedure. So there is no complication of there are low complication rate of bleeding related to the procedure, and the procedure is safe than the traditional surgical surgery for the BPH. The patient's prostate is 170 ml in volume. It's a large prostate. Today we will use a prostate embolization to reduce its volume and improve its lower urinary tract symptom. First, we puncture the left radial artery, and we go the HH1 catheter, which is a Merit. The manufacturer is Merit. The diagnostic catheter with a specific curve that makes us easier from the transradial approach into the distal abdominal aorta. And we have reached the distal abdominal aorta, and we have an angiogram for the iliac artery. We want to go into the internal iliac artery, which the prostate artery is located in the internal iliac artery system. But now we have to have a road map, and we want to use this road map to facilitate our catheter into the internal iliac artery. 不是，问题是路途没有出来。Can we have a road map? Okay. So if the road map is not available, we use a bone marker to go into the internal iliac artery. We have some difficult to conquer this curve. There's some maneuver can cover conquer this situation, but I want to go to the left side first.
Is it an MP catheter you're using?
No, I use a specific curve catheter. It is called a HH1 catheter. It's a 5-French diagnostic catheter.
So you're in the internal, left internal.
Yes, I'll go into left internal first because we don't have a road map current. 应该是什么哈 ？Okay. After we go into the left internal artery, we can give okay.
So you're going from the left radial?
Yes, to the left internal iliac artery, and we'll take another angiogram and to see which is the prostate artery.
And how long the catheter do you need to reach?
Yes, it's very important. You should have a long enough catheter to proceed with the PAE smoothly. The HH1 catheter is 125 centimeter in length. Okay, we'll take a, okay. We use the ipsilateral side for the angiogram first. So if you the angiogram is taken in this position, you can see the posterior artery from type 1, type 2, type 3, type 4, or type 5. Oh, okay.
Yeah, so we see the prostate artery.
Yeah. Can you see the first branch here, yes. The small branch from the 1 o'clock to the 7 o'clock in direction?
Yes.
荧幕看得到吗？这个。
Okay.
Okay, this is a superior vesical artery. If your prostate artery is divided from this area, it's called type 1 prostate artery. And if it is directly divided from the anterior division of the internal iliac artery, this is the anterior division of the internal iliac artery. It is called type 2 prostate artery. We can see any evidence of that prostate artery originating from type 1 or type 2. So I suppose the prostate artery is from the obturator artery. So we'll use a microcatheter to check a selective angiogram to see if this originates from this branch or this branch. It is all from the obturator artery. If it is true, the prostate artery may be type 3 prostate artery. Merit micro. We will use a Merit microcatheter. It is with soft tip, so it is very safe. And we will use a gooseneck microcatheter, so you can have a more angulation for the probing of the orifice of the prostate artery.
Okay, Dr. Please carry on your work, and
okay,
we'll leave it temporary now, and then we'll come back to see show prostate arteries.
Okay, thank you.
We shift to room 2 to see the Dr. Lee for here gesturing after gesturing. Dr. Lee? Dr. Lee?
What?
Dr. Lee?
Yeah.
We are come back.
Previous
so after you gesturing, what's happened now?
After gesturing masterectomy, the following angiogram showed no reflow phenomenon. The kind of situation sometimes occur. This kind of very long, diffuse long region with a bulky material inside of the old region. So that is several mechanisms. The one is some dissection. The second one is even in case of CTO, distal exit is not opened yet, that this kind of situation can be occurred. The third one is debris is filled with region. And the fourth one is debris filled with a filter device that block the blood flow. So what do you think for this case?
I think for this might be distal embolization.
Distal embolization?
Yeah, it's just so, the filter trapping all the embolies and causing no reflow.
Yes. At this moment, I use a suction catheter. 6 French, 7 French, or 8 French suction catheter is very useful for the small removal of debris, and then we can inject contrast inside of the region like this. Okay, you can see there's a flow is good for the P2 area, but there is no reflow at P3 area. That means debris is filled with a filter device. So I want to do a balloon angioplasty first, then DCB angioplasty, then I remove the filter system. If the patient complains severe pain, I remove the filter system first and introduce another way and do a procedure. But the patient is stable, so I do a IVUS first, then balloon angioplasty and DCB angioplasty, and finally I remove the filter system. Okay?
Right. Okay. So totally, any kind of tips and trick to prevent this kind of no reflow phenomenon?
We cannot prevent that because, but very slow to and fro motion is very important. But if you also, I already tired, so my speed is a little bit high. That's the one problem. A slow motion is important, I think.
Yeah. What about anyway, kind of like a cocktail with nitrite, verapamil, and nitrate, those vasodilator?
I always use nitroglycerin before the intervention. Always use almost 1,000 microgram already given. Yes.
Okay.
I'll show you the IVUS finding for this case.
Okay, Dr.
Please hold on.
Please keep on your work. We'll back again later.
Okay.
We will now shift to room 1 to see
area, please.
how the OCT result. Dr. Chen?
Yes,
it
hello.
seems that
yes.
you finished your OCT. Can you show the OC result to us?
Yes, okay, we will show the OCT image. Okay, this is our OCT image. We play the image now. Can we see the image?
Yes, very angry looking calcium.
Yes, I think in the most severe critical part, there is the calcified nodule. I will fix the image and here. Yes. So you can see maybe in the 10 to 11 o'clock, there is a calcified nodule protruding into the lumen. And the vessel size, I think the diameter may be 3 by 5 millimeter according to our measurement. So maybe I try to hawk the calcified nodule as possible. Okay, so I will try to start my first pass now.
So Dr. Chen, well, it's very nice to see visualize the calcium nodule on the OCT. But yeah. I mean, when you're doing the case, is there any way you can control your cut to the calcium nodule?
Yeah, I try because it's in my first round now. Because let's see. Yes, I think maybe I will, because you can see maybe the filter, we know because the Hawk system, the tip length is around 6 centimeter, and so we should save some space from the filter to the Hawk 1 device. So I'm not sure if the Hawk can cut the most critical part. So I try to do my best, try to push down the Hawk device. Because maybe I cannot touch the some rotational speed slow down, but it's very difficult to push down. So maybe I will try to use the small balloon to dilatation first, because it's not easy to hold. The filter already moved. So I try to pull back a little bit, try to leave my filter here, and I will use the small balloon to dilate here. Oh, 我们有3.0保论。啊，对。保论哦。有80还是100？
You will use a high pressure balloon or regular balloon?
Regular balloon. I will use the regular balloon. because like I said, the Hawk device actually still big. So if the 7-French Hawk one, I think according to the data, maybe the shaft diameter is around 2.6 millimeters. So I will use the 3-0 balloon to dilate first. Then I will try to pass the Hawk 1 device again.
So is there any comment from the commentator?
For this kind of calcified nodule, because this location I think is in the pulp.
Yeah, so the target lesion is very close to the filter side.
Yes, yes.
And also the
actually
filter
this
tips, usually you do need a bit more length between the filter and the Hawk.
Yeah, I think this is
so you might
most
need to
big.
pass the filter a bit lower.
This is the most difficult part if we want to use Hawk here.
So Dr. Chen, will you give any pharmacological prevention for the no reflow phenomenon? Just
I think if
because we see another case, they have this no reflow phenomena after.
Yeah, I think if no reflow most of the time because distal embolization we create during the arthrotomy device. Okay. So maybe one option is if we can use the proximal protection device. Maybe this is another option. And another option is, okay. Sometimes in the early time we can use the blood pressure cuff in the lower limb to stop the flow. But you need to finish the procedure quickly as possible to prevent the ischemia time. After you finish the arthrotomy device, you need to aspiration and do the angio. I think this is another option you have. Or in the end, maybe use another device. That's the other option. Okay, this is 3-0 balloon. I think the balloon is dilated. And I will try to pass the Hawk device again.
Hey, Dr. Chen, will you do a different angle of angio to see what's the best view or image for directional arthrotomy?
Okay. Okay. Because from the intravascular image, maybe we already know the lesion size, so maybe by Dr. Xue's suggestion, I do another angle. I use the LAO view. I do another angio shot. Okay, contrast. In the contrast. Okay, so I try to pass the Hawk device again. Yes.
You have a very short runway to your Hawk.
Yes. Okay, Hawk.
Dr. Chen?
Yes.
I am Dr. Lin from Chang'an. And how
Yes.
to choose the adequate size and the location of spider filter?
Okay, that's a very important question. Just like I mentioned, because the filter, you need to keep a distance away from the hook tip. So according to the recommendation, the hook tip maybe size is around 6 centimeter, and you need to keep at least more 3 centimeters. So I think it would be better if you keep maybe 9 to 10 centimeter. It would be better. So for this case, it's very difficult because landing location is very difficult to choose. And luckily, because the ATA is accredited, so I just try to put my filter wire in the TV trunk to prevent the distal embarration to the PDA. Okay, I try to pass again. Still very difficult to push down. 有干伤，干伤。Maybe the hook cutter is still maybe in the P1 not to the P2 segment, and the tip already maybe very close to the filter, and still very difficult to push down. So I'm afraid maybe the hook device maybe they cannot cut the location we want. So maybe, I think at this moment, maybe I can only change my plan. Maybe.
So you will change to another device?
Yeah, yeah, because like you see from the
Dr. Chen, please keep on your work. We will shift to another room and
yes.
come back later.
Okay.
Okay, Zhangji room 2.
Next, I'll check the length after this one. Okay.
Hello.
Roshi.
This is
Dr. Lee, we are back to you.
Dr. Lee, yeah.
I am still doing after balloon angioplasty. Yeah, image. Okay. Okay. This is live image, final image. Okay. 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 Large one. Okay. After balloon angioplasty, because we found that the P2 area EM diameter is about 5 millimeters, so we choose 220 Sterling. Personally, I prefer to use the NC balloon in this kind of situation, but NC balloon is not available. So I use a semi-compliant balloon proximally and distally, each for the 250, almost 3 minutes. Then I check the angiogram again. The flow is a little bit better than the previous one, but anyway, I'm doing a DCB angioplasty. This is a Ranger 5020 for the distal part, and I have chosen another 5015 for the middle part. Maybe according to previous balloon, is a 220, that is a little bit short, so I need a 3 DCB balloon for this case. So I apply 50 for the mid SFA, and finally I apply 60 for the proximal SFA.
I think the balloon expansion looks good too, even with your
yeah.
paper.
Yeah, balloon expansion is well done. There is some resistance point, but according to the, let me see the IBUS first. IBUS. Elliot. IBUS 틀어줘요. IBUS. Turn on the IBUS. After IBUS on. Elliot. IBUS. Play IBUS. Play previous image. Play. Okay. Rapid run. There is a this is distal P2. Rapid run. Run a little bit faster. Distal P2. Faster. So slowly. A little bit faster. Okay. There is a calcification still visible, but debulking is effectively done. A little bit faster. Yeah, this is the proximal part of SFA. There is an encircling calcification, but luminal gain is, I think, enough for the atherectomy procedure. The proximal SFA, more. This is the proximal SFA. There is a plug here, more. This is SFA ostium and SFA ostium. Okay. So I'll do a DCB angioplasty and finish it up. After removal of the filter wire, finish the procedure. If there is some debris noted after the procedure at the BTK arterial level, I'll do aspiration, suction aspiration with a suction catheter. Okay, 갑니다. Keep the wire in the same position. Okay, in play here. In play. Okay. This is a Ranger DCB balloon, 50150. Okay, 10. 12.
Okay.
2 minutes. Okay. I'll do a DCB angioplasty here and here. Then I'll remove the filter system and check the angiogram.
Right.
Are there any questions or comment from the?
Were you concerned about possible intravascular thrombosis if there is no distal runoff and prolonged balloon expansion?
I hope there is no the flow will be improved after removal of the filter wire. I hope so. I don't expect any nodipro or embolization after this procedure. Elliot, I think it's 200 maybe need. Yeah.
Dr. Lee, I'm sorry, we should leave this temporary now and go to another room to see that case. So we'll come back later. Thank you.
Thank
Take
you.
care of your work.
Okay.
我们到中国 room 1。Dr. Zheng?
Hi.
Yeah, you are on air.
Hi, Dr. Zheng.
Can you
Yes,
show me the
okay.
prosthetic artery?
Okay. We have isolated the left prosthetic artery. It is a type 3 prosthetic artery, which means that it is originated from the left obturated artery. And I will show you the angiogram later. Now, after confirm the vessel, we will see if there is any collateral should to management first. But fortunately, we have the patient did not have abnormal collateral, so we just embolize the left prostate artery. 放一下前面大概3个 round， 4个 round 啊。再前一个好了，再前一个。再前 ，OK， 再往前面。要不然这样，this is a angiogram for internal pudendal artery. We check this to see if there is a significant collateral from internal pudendal artery to supply left prostate, and as we can see, there is no significant collateral to the prostate. It's very common to see a collateral from the internal pudendal artery to the prostate area. Okay. If the prostate artery is originating from the internal pudendal artery, we call this is a type 4 prostate artery. Now you can see this is a obturator artery. We guess the prostate artery is this branches, so it is from the obturator, so it's a type 3. So we to make sure of this, we have our microcatheter into the branch of obturator artery. This is obturator artery. Okay. After our microcatheter go into the branch, you can see there's a critical stenosis over the prostate artery. In our experience, if there is significant stenosis over your prostate artery or your internal pudendal artery, there is a very high incidence that you have severe stenosis in your coronary artery. The patient have received stenting 3 months ago, so he definitely is a victim of coronary artery disease. And so we have a selective inject in the prostate artery, and this is a lateral view. So I changed to PA view to confirm this is a left prostate. 下一个 PA view 好，转到 PA view。对 prostate PA。Okay, as you can see, this is the left side of prostate artery. You can see your casebook. It is the same appearance as the transabdominal echo. Okay, so when we see the anatomy of prostate artery, and to see if there is any collateral and there is any incident chance for non-target embolization. If there is no risk of this, we can go through the embolization with microsphere. The size of microsphere may be range from 100 to 500. I will call you the prostate artery first by 3 to 500 microsphere. If the result is not good, I will add additional 100 to 300 microsphere. Microsphere is a small particle, and it can be resolved. It will permanent in the vessel, so it can occlude the target vessel permanently. But when you inject the microsphere, you should be very carefully to see the flow and to prevent non-target embolization. Lateral view, 回到 lateral view. Okay. I put the microcatheter more distally and gently push the microsphere. The microsphere is mixed with our contrast, so you can see the contrast over the distal portion of prostate, and you can see their reflux over the tip of microcatheter. So I stop and inject more slowly. As you see, the contrast still stays over there. So maybe I will put my microcatheter more distal and to prevent a large amount of reflux. If the microsphere reflux high enough, you may go to the normal tissue of this obturator artery. So I put the microcatheter more distally, and I want to embolize this left prostate artery by microsphere only. Okay, as you see, and the contrast disappear. So you can inject more and more microsphere until to the stasis of the vessel.
Okay, Dr. Chen, I'm afraid we are leaving you now.
Okay.
And we'll come back later. Thank you.
Okay. Thank you.
Ship to Zhangji room 1.
帮我放，对啊，帮我放上面，谢谢。
Hello.
Hello.
Hi, I'm Dr. Zheng. You are on air. So you are from the 10 case. Can you introduce your case and your team?
Okay. Are you calling me or? Yes. Oh, I'm Dr. Liang from Zhongshan Medical University Hospital, and today I will bring a case of Tammy. And this patient. Can I see my history on the slide? And this is a middle-aged woman who underwent several arthroscopic surgeries and PRP injections. Yeah, here's my slide. She complained right anterior knee pain, and especially when resting. And she also had tenderness in the anterior joint line and the lateral aspect of the patellofemoral joint. Next slide, please. And he underwent arthroscopic knee surgeries twice, and several oral painkillers and the PRP injections, but he complained there's no improvement. Then the MRI performed in last month showed still some increased synovial enhancement, and also she had a lateral patellofemoral ligament tear, and the anterior horn medial meniscus also showed some injury and inflammation. So today's plan is to use Tammy to treat the anterior knee pain. So this is the brief history. Next slide, please. And here's her MRI findings. The left one is the medial meniscus anterior horn, has some increased enhancement near the meniscus, and the lateral, the right side is the lateral patellofemoral ligament tear. And she also complained painful area. If you can see the furrow, I put the marker there so you can see the dark marker in her anterior knee. So I just performed the angiogram on AP and lateral view. So this is my guide to the treatment. Next slide, please. So this is the required equipment that used for GA or knee TAMI. Next slide, please. And this is the corresponding painful area and the supplying arteries in knee. Usually we have a branch to check if it is necessary to give embolizers in it. And the next slide. And this is the anatomy of the A branches of the knee arteries. So we will check one by one in this patient and decide if we need to embolize these branches. I think this is my brief introduction to this patient and the procedure.
Okay, thank you. So you have your angiography now? No?
Well, already done. Okay. So I'm not sure if we can see the reference. Yeah, this is the lateral angiogram. So we can also see some branches here. Maybe we are planning to castrate each of them. So maybe I can introduce which arteries we are in, and after we castrate each one.
Okay, Dr. Yao, thank you for your introduction. And now we map to shift to another room for another case, and then we'll come back.
Okay.
Thank you.
Okay.
Room 2. Dr. Lee. Yeah. Dr. Lee. Dr. Lee. Dr. Lee, can you hear me? 导播 中国 room 2, please.
真的吗？不是。哦天哪！满清十大酷刑。
Hello, you are on air again.
OK, 我去听。
Dr. Chen. 应该不是，应该是。
Dr. Chen, can you hear us?
Oh, okay. We shift to Zhangji room 2 to see the Dr. Lee's result. Can we shift to Zhangji room 2? Hello, Dr. Lee. Dr. Lee.
I will explain the fine. Yeah. Hi, can you hear me?
That you finished your case. Can you report the result?
Final angiogram.
Okay.
After next one. No, final angiogram. Okay, I'll do it. After 3 dCB for the proximal, middle and 3 dCB, and after removal of the filter wire, and this is the final angiogram. So flow was improved, and there is no embolic debris noted at the distal part of the patient leg. Yes, and there is some small dissection is noted at the mid SFA, but I think that was no problem.
Yeah, looks
this
amazing.
is our final result.
Yeah, looks amazing.
Nice result.
Very nice.
Yeah, this is an advantage of the atherectomy system for this kind of very calcified region.
It looks amazing result. Congratulations.
Congratulations.
Thank you. Thank you very much.
Okay, Dr. Chen.
Okay. Dr. Chen. Dr. Chen.
哎，对，哎，还有对面吗？好。哎，俊吉怎么好像没有反应？没有反应。
Dr. Chen, can you hear me?
好。
他们有讲话，有听到吗？
有。
Dr. Chen.
Yes.
Yeah.
So we just finished our final OCT image. So let me review my strategy after the Hawk device can pass. So because the arthrotomy device cannot pass, so I choose the spatial balloon using the chocolate balloon because we know chocolate balloon is a device you can let your vessel preparation better. So according to the OCT size, I think I choose the 40 by 18 millimeter chocolate balloon to do the vessel prep. And this is the angel after the chocolate balloon. So you can see the lesion already dilated. Then I use the 40 by 80 DCV at the mirror in play for 3 minutes. And this is the final angel, and we do the OCT.
And I also do the small balloon dilatation for the TB trunk. So you see this is the final angio after the chocolate balloon and DCB treatment for the pop. And we also can see the OCT image. Can you see the OCT image?
Yes.
Yes, so you can see the OCT image we pull back again. So I think that previously the calcified nodule already very well dilated by the chocolate balloon and the DCB. So I think the lumen area is big enough. So this is the final angio after we use the chocolate balloon and DCB treatment for the popliteal artery. So any comment?
Yeah, I think the result is very nice.
Yeah, so I think because this lesion can be treated by different ways. So if we have the accelerator device can pass smoothly, I think you can get a better lumen gain. But if the device can very difficult pass, maybe using some special balloon like the chocolate or cotton balloon to dilate the lesion and use the DCB, I think the results still very good.
Okay, that's a very nice result, and thank you. So congratulations,
Okay.
Great result. So we
Okay,
are leave
thank
you
you.
now, and we can thank you again.
Okay, thank you.
通过 round one.
Okay. After we have several shots of injection with microsphere, about 4 ml of microsphere, we found out that here the left prostate has a significant collateral from the inferior vesical artery and the branch of obturator artery. So you can see, can you see the angiogram? This is a superior vesical artery, and this is a branch to the inferior part of the bladder. This is the one branch of obturator artery. We can see the distal portion is supply prostate. So so we have to coil this microchannel collaterals to and make a more complete embolization of left prostate. Because it needs a real-time roadmap flow, but it is not available here, so there may be a challenge situation. You can broadcasting another room, and I will show you after we complete the embolization. Okay?
Yeah.
Okay. 好的，那我们
Dr. Zheng,
Hi.
Do you do the CT angiography before the PAE?
Yes.
To
I think
prevent non-targeted embolization. Thank you.
Yeah. I think if you have a CT angio, you can predict what type of prostate artery in advance. But like this small channel, the collateral CT angio not always show this flow, and it is hemodynamic. We can see this collateral just after we have embolized the prostate artery as this case. We embolize the main trunk, and the flow decrease, and the collateral will show up. So it is almost impossible from the CTA before the procedure. So, but if the patient has severe atherosclerosis, it is impossible or it's very difficult to engage the left prostate. It is helpful for pre-procedural CTA. So I do not routinely perform CTA, but I think it is a good modality for the pre-OP evaluation.
Okay, Dr. Zheng, thank you for your excellent case. I'm afraid we will leave you now, and we get another case. So thank you again. So congratulations. 张基荣 one.
现在在我这吗
Dr. Liao.
Hello. Okay. Now, can you see the image?
Yeah, we see the image.
Yeah. Now we are in the number 1 branch, which called suprapatellar branch. And this branch is supply the superior portion of the patella as well as the insertion of the quadriceps tendon. And after we catheterize it and use angiogram to test if patient had evulpen in his knee, and he said this is not related to his pain, so we will skip this artery. Could we move back to the previous arteries? And please show the DSA for me. This is the number 2 vessel called descending genicular artery, which supply the medial side of the femoral condyle as well as the meniscus. And after the supraselective angio, patient complained pain in his knee, which is also the same location when she always felt in the daily times. So we embolize this vessel with imipenem, which is antibiotics that we mix in 5 milligram in 10 cc of iodine contrast. We inject about 1.5 mole of imipenem in this branch. And the previous one, yeah, this is the superior medial and the median genicular artery, which supply the medial femoral condyle and the intercondylar notch. And this, in this angiogram, and patient also complained the knee pain that she always felt. So we embolize these 2 vessels with 1.5 imipenem particles. So now we are going to catheterize the other 5 branches in the following procedure.
Okay, Dr. Liao, thank you for your excellent demonstration. But the transmission time is up, so we must leave now. Thank you again.
Okay.
Okay. So, double room 2. Now I will invite Dr. Chen Junqi to give this section's closing remark. Dr. Chen?
Hello. Yes.
Yeah.
Yeah. Yes. So
nice to you again.
think
Can you give the close remark for this section? Thank you.
Yeah, I think today's live demonstration is very successful, and I think every operator and every panelist work together can give us a nice result. And every lecture also very helpful for our clinical practice. So I thank every speaker here today. I think tomorrow we have another day meeting, so welcome everyone can join us meeting tomorrow. Thank you. Thank you.
Thank you all of you for your participation. The section is closed. Thank you.